Hello, and thank you for joining me for this recorded program on stroke quality measures, improving quality through order set utilization and documentation. This will also include an abbreviated review of the guidelines for the early management of patients with acute ischemic stroke. Kearney Regional received its primary stroke care certification in February of 2020. It is a 3-year certification. So part of the reason why we wanted to do this program is really just to educate providers on the stroke measures that we have to meet and maintain for our certification, and then really to look at the order sets that are available to help meet those quality benchmarks related to stroke. The stroke quality QAPI goal for 2020 is to increase compliance with using the order sets so that we can really utilize best practice for stroke care by integrating those updated guidelines into our order sets and into the day-to-day care of stroke patients at Kearney Regional. So quality really does begin with knowing what the best evidence is and for the treatment of any particular pathology. For stroke care, our accrediting body, HVAP, mandates that we have 5 continuing medical education hours related specifically to stroke. For program leaders like our director of our stroke program, Dr. Crandall, and our inpatient stroke care champion, Dr. Ghosh, the number of hours actually jumps to 8 annually. So HVAP does say that we can include things like hospital in-services. So please make sure you fill out your evaluation and attendance for this class because that will count towards your hours. There's also CME offerings online. I know through the hospital, Up to Date, any article that you look at for stroke tends to be worth about 0.5 CME Category 1 credits. I know there's a few things through Medscape, and then of course any live offerings or conferences. I do just like to remind people that if you provide the listing title and the CME certificate to credentialing, that really helps them actually know that it goes towards your stroke credits rather than if you just provide that certificate that says the total number of CME credits. So order sets were developed with Dr. Ghosh, again, our inpatient stroke champion, along with input from the HVAP Primary Stroke Center standards, and then also the American Stroke Association's guidelines for the early management of acute ischemic stroke. Now, there was an update in 2019 released in October to those 2018 guidelines, and so the last time we sent these through medicine, we made a few changes based on those. Copies of the order sets can, of course, be found on KRMC's ODrive, and I'll also send those out with the recording of this webinar. So if you have any questions or concerns, please refer to those order sets. I do like to say my easy cheat for finding order sets is I will go to the ODrive and go to the protocol and order set manuals folder, and then I just type in stroke and it brings up really everything that we need related to stroke. So a couple things to note with order sets. These can be used as admission orders, so there's not an additional need to use both the KRMC admit order and the stroke order set. Commonly, we're going to see that the acute ischemic stroke or TIA care order set is used. These are for patients who did not receive TPA, whether they're admitted from the ER or as a direct admit from the office or another facility. If the patient does receive TPA, they're going to be admitted usually to the intensivist first, with care transitioning to the hospitalist or primary care after the first 24 to 48 hours, really depending on the individual patient's course. We do have an order set for hemorrhagic strokes, but we do transfer these patients because we do not have coverage for neurosurgery. But if there is some reason we would have to hold the patient, we do have that order set to help guide us as well. Another thing to note, there is the stroke inclusion exclusion criteria for TPA, which is really useful for your stroke alerts on the floor to help make that decision along with the teleneurologist, because ultimately that decision does rest on the KRMC provider's shoulders. So really, to start off, this slide is just an overview of all of the different measures that we report to our accrediting body. We also report these to the American Heart Association, who we use as a data repository. We use the Get With the Guidelines tool, and the AHA also helps us with some quality improvement, as it has some different awards criteria based on how well we perform on many of these different items. So the bold-faced measures, stroke measure 1, stroke measure 2, 3, 5, and 6, are also things that we report to CMS as part of our overall quality rating. So you can see that stroke care really does touch on a lot of different aspects of overall care at our facility. Now, I'm not going to read each of these measures to you individually because we're going to go over them as we go over how we've integrated these measures into our order sets. As we discuss the purpose of this education, I really want to emphasize that we want the data that we collect related to stroke to be actionable to the care that your patients are receiving. This first graph shows how we're doing on stroke measures 1 through 10 for all of 2019. It also includes the National Institute of Health Stroke Scale measure, which is not something that we report to HVAP, just happens to come on this canned report. Our goal really is to be at the 85th percentile. The line on this graph is actually at the 90th percentile, but for 2019, you did an excellent job in meeting this goal on everything but prescribing anticoagulants at discharge for patients with atrial fib or atrial flutter. So that green stroke measure 3. Now, what I will say with this is the issue really comes down to if we only have a handful, 4 or 5 patients that have an acute ischemic stroke, that have a history of atrial fibrillation, and we don't send them home, it can only be 1 or 2 patients that really knocks us down to the 60th percentile if we only have a total of 4 patients or 5 patients. So this is the same graph for the first quarter of 2020. And so far, we're doing okay on meeting those goals, but we're definitely seeing a negative trend in the discharge on a statin and the stroke education goal. So we'll talk more about what we're doing to help improve those numbers as we go on. So I thought really the best way to approach this was to look at the individual stroke measures, the research behind those measures from American Stroke Association guidelines, and then try to loop that back into what's included on your standard order sets. So stroke measure 1 requires VTE prophylaxis on all ischemic and hemorrhagic stroke patients. So stroke patients are really at an increased risk for developing venous thromboembolism. PE actually accounts for about 10% of deaths after stroke, and risk is even higher for those with a paretic extremity. So the gold standard treatment for this is IPCs or SCDs for the immobilized patient, and severely ill patients get anticoagulants added. SCDs are included in all of our order sets. For those receiving TPA, medication administration is delayed 24 hours. So when we look at the documentation for this, Contraindications must be documented in the context of VTE prophylaxis. So if the patient has a pre-existing bleeding condition or an allergy to heparin, you have to be explicit. During abstraction, I can't, or the abstractor can't assume that that's the reason, even though we necessarily know it is. But things that you can document, no VTE prophylaxis because the patient is ambulating, the patient's already anticoagulated, they have a therapeutic INR, and comfort measures only. So things that we have on our order sets, we do have our sequential compression devices auto-checked. We have the Lovenox or the enoxaparin 40 milligram sub-Q auto-checked as well. And then for ambulation, we have physical therapy auto-checked, which we'll talk more about that on the rehab measure as well. Moving on to stroke measure 2, this one says that all eligible patients with ischemic stroke symptoms should be discharged on an antithrombotic. I really want to stress that this is all patients presenting with ischemic stroke symptoms. So this measure does include TIAs as well. I also highlighted over here again that you can have a documented reason under the exclusions for not receiving an antithrombotic. But again, it has to be documented in that same context. So you have to say no antithrombotic due to patient allergy. An allergy is kind of a hard one because an allergy or an adverse side effect to one antithrombotic may not really preclude you from prescribing a different type. Again, you have to be kind of explicit here. So in 2019, we dismissed 87% of our patients, of our stroke patients, on an antithrombotic. The research says that low-dose anticoagulants are not sufficient to prevent recurrent stroke or TIA. So in this instance, let's say you have a patient that's on Xarelto 10 milligrams every day for the prevention of DVT after a hip surgery. That Xarelto dose is not going to cover them for TIA or stroke prevention as well. Increasing the dose to 20 milligrams daily or 15 milligrams daily in patients with renal failure would cover them. Additionally, there's strong evidence to support that patients with non-cardioembolic AIS, the use of antiplatelets rather than oral anticoagulants is recommended to reduce the risk of recurrent stroke or other cardiovascular events. So we don't have a standard discharge order for our stroke or our TIA patients. So these really do rely on your expertise in the matter. If a discharge order set is something that you'd like to pursue as a group, please reach out to me and I'd be happy to help with that. In the meantime, acceptable reasons not to give antithrombotics on discharge are listed here. Things like our allergies, bleeding disorders, if they were hemorrhagic, they're planning to come back for surgery within 7 days after discharge, or maybe you've got them on comfort measures. Stroke measure 3 is anticoagulants prescribed at discharge for atrial fib or atrial flutter. Now, this is another, like I said, discharge measure. So this one says it includes both new onset and those with a prior history. So even if the patient's in normal sinus rhythm during their entire stay, if there's documentation in their history that they had AFib or proximal AFib, they have to be sent home on an anticoagulant. The American Heart Association suggests that in the setting of atrial fibrillation, it's reasonable to initiate oral anticoagulation between 4 and 14 days after the onset of neurological symptoms. The usefulness of adding antiplatelets to oral anticoagulants has not been well established in the literature. except for in unstable angina and coronary artery stenting. So those are some special circumstances where dual therapy may be warranted. So Kearney Regional's average length of stay for a patient with a minor stroke is 4 to 5 days. So it makes sense really that this is a discharge measure. The second thing I really want to stress is this has to be an anticoagulant. So aspirin, for instance, is an antiplatelet and is considered antithrombotic, but would not count towards this measure. These patients can go home on a Lovenox to Coumadin bridge if they're able to manage that, but of course the newer drugs may make compliance a little bit easier. Another thought to the newer drugs include decreased risk of hemorrhagic stroke and fewer interactions with other medications and foods, rapid onset, and of course, freedom from blood test monitoring. I think that's really all there is to say with that one. It's pretty straightforward. You know, we're definitely seeing a lot of patients on the Eliquis or the Xarelto. Like I said, Lovenox, the Lovenox to warfarin bridge, if the patient can manage that, can start as well. If for some reason their INR is supratherapeutic when they're getting ready to go home, again, that's where your documentation comes in. If you can say, you know, their INR was 4, we told them to hold their Coumadin today and start it tomorrow. That works as well, as long as that's completely spelled out. So stroke measure 4, thrombolytics given by 4.5 hours of last known well time. Of course, is pretty emergency room specific, but I just wanted you to be aware of this one. Patients really must arrive within 2 hours and be treated within 4.5 hours. HVAP standards is a little looser than the quality measures with American Heart Association. They're still looking at the 4.5 hour mark, but American Heart is narrowing that window to 3 hours. And I think we'll continue to see that shrink over time. Stroke measure 5 is antithrombotic therapy by the end of day 2. There has been some confusion about the counting of days as well. So I do just want to clarify the date of admission is day 1, or if they experience a stroke while they're in the inpatient setting, it is the day of discovery is considered day 1. I know for some other quality measures, admission date is 0, but for stroke, that's just not the case. So this one again is going to include our TIA patients as well. The exclusion criteria come down to documentation again. Is there a reason why they could not be prescribed an antithrombotic? Are they, and again, this one specifically says allergy to one antithrombotic does not preclude the others. So maybe one of the critical access hospitals dripped, they TPA'd this patient, but then they sent them to us and you take them as a direct admit. Document that they received TPA at that outside facility. The other thing to remember is with this measure is that VTE prophylaxis is not sufficient coverage as an antithrombotic. So we talked earlier about the 40 milligrams of Lovenox being checked for VTE prophylaxis. That doesn't count towards their thrombotic. So other things that are on our order sets that do are our aspirin 81 or 325, the Plavix 75 milligrams, and then of course your Agrinox and your Coumadin. If you did increase, for some reason just decided you wanted to keep them on Lovenox and you increased it to the milligram per kilogram dosing, that would cover them for an antithrombotic. Again, when they start out with that TPA order set, we will have these medications on there, but it explicitly says they're starting 24 hours after the end of that infusion. Stroke measure 6 speaks to another discharge measure. So if you're counting, we have a discharge on an anticoagulant for AFib, everyone gets an antithrombotic on discharge, and everyone needs a statin on discharge. That's really 3 discharge-related measures. And actually, the inclusion criteria says that it's all patients with an LDL greater than 100, or if the LDL is not measured, or if they were already on a statin, or I'm sorry, not even a statin, but just a lipid lowering medication prior to arrival. So this is one we tend to struggle with as a facility. If you remember those graphs at the beginning, 2019, we dismissed 78% of our patients on a statin. And for the first quarter of 2020, we're looking at right around 83%. So we're not meeting that benchmark of 85% quite yet. Part of the issue is that I think it really came down to the fact that we're not ordering those lipids. So some patients that could be possibly excluded are getting included just because we're not ordering that. So what we did is make sure that the lipid panel is checked on all of the different order sets. Exclusion criteria with this one are, of course, going to include that allergy to statin, but it does have to be documented as an allergy by the provider, not just as an intolerance. And then, like we said, if their LDL is less than 100, those are going to be excluded as well. On a side note, if they do have high cholesterol and they need a smaller dose related to statin myopathy, document that as well. There is an achievement measure, which we're not covering today, that speaks to prescribing high-intensity statins, which are usual of 40 of atorvastatin will cover. But if they can't tolerate the high dose, we need to know that in the documentation as well. This is really supported by the evidence, which says that patients at increased atherosclerotic cardiovascular disease risk with statin-associated myopathy receive a statin rechallenge. And then if that fails, it's reasonable to use non-statin therapy with clinical benefit. It's also reasonable to start that statin while they're in the hospital setting and have that continued upon dismissal. So the lipid profile is really effective in estimating that ASCVD risk in adults greater than 20 years old. And then in patients that are under 75, clinical ASCVD should receive that high intensity statin. Now, it is okay to use statins with patients with chronic stable liver disease as long as we get that baseline and then we follow up that monitoring. If we're not ordering a statin, again, if not, why not? Can they tolerate a low intensity? Are we not giving it to them because of their age? Have they refused it because, yeah, they're 85 and they don't see the benefit in it? That's okay as long as we document that. And then, of course, comfort measures only is going to exclude us from most any measure there is. So we skip now to stroke measure 8. For some reason, there's not a stroke measure 7 or a stroke measure 9. But this one addresses ischemia and hemorrhagic strokes, caregivers who were given education materials during their hospital stay. This is a pretty nursing specific stroke measure, but if you document education or you drop TIA or stroke on their discharge education list, that certainly helps us. Other things that the providers can document include any treatment or recommendations about smoking cessation, diet recommendations, whether you're putting them on the DASH diet or they need to follow up for diabetic education, any recommendations you make regarding lifestyle change, losing weight, increasing exercise, all of that can really fall into some of the different measures. On our last update of the stroke orders, we also set in or built in a consult stroke program coordinator to help increase compliance with the education measure, because this was one that was getting missed here and there as well. A lot of times, the patients that were missing this measure were those that were direct admitted, or we came up with a diagnosis of TIA after they were admitted. So maybe we worked them up in the ED and we admitted them altered mental status, and then a couple days down the line, your final discharge summary says TIA. So that consult stroke program coordinator actually prints to the ED so that I can get a notification of that and follow up with that patient while they're here. Because especially those guys that don't come in through the ER, that we get transferred from an outside facility, I may not know about them any other way. Stroke measure 10 is assessed for rehab. It is recommended in the guidelines that all individuals with stroke be provided formal assessment of their activities of daily living and their instrumental ADLs, communication abilities, and functional mobility. Stroke measure 9 addresses that all stroke patients need to be assessed for rehabilitation services. So when I first started at KRMC and asked the multidisciplinary team that was working on stroke certification what their needs were, this was one of the first things that they talked to me about. Rehab services felt like they weren't being consulted soon enough. And while there's very little evidence regarding the timing to rehabilitation of stroke patients, we all understand that it really should be starting within the first couple of days in order to improve the long-term outcomes for these patients. Now, the stroke measure specifically addresses physical therapy, and then OT and speech language pathology can be on a clinical need. But the team really felt that just consulting all three right off the bat would be appropriate. So it does have just consult, PT, OT, and speech therapy for evaluation and treatment on all of the order sets. If we transfer this patient, within usually the first 24 hours, of course, they're going to be excluded from this one, but it does get them moving if we're looking at these measures. Sorry. We'll move on to stroke measure 11. So stroke measure 11 addresses the number of patients who receive a dysphagia screening prior to receiving anything by mouth. And so this is an all patients measure. So whether they're TIA, whether they're hemorrhagic or ischemic, and the exclusion criteria do state that TIA patients can be excluded if clinically indicated. The problem with that one is, again, documentation. Usually we don't have the documentation to support excluding them. So between 37 and 78% of stroke patients will have some amount of dysphagia. With this higher risk for aspiration pneumonia, the impact on patient outcomes, and all patients should be screened prior to any PO intake. So ideally, we want this to happen before they leave the emergency department. So we have been concentrating a lot of education there. The difficulty comes again when the patient is admitted for weakness or altered mental status rather than an actual stroke diagnosis. We tend to miss the opportunity, and then later they're found to have a stroke. For example, what happens is in the ER, the doc works them up and they have a negative CT and a negative CTA, but the next day maybe you order an MRI and there we see the stroke. So we do use the Yale Bedside Swallow. It is just simply a water challenge. And we're working on increasing the screening for that for many, many diagnoses in the ED. But it is the largest potential complication. Another misconception that nursing staff has had is that it has to be done by speech, which is not the case. So the 2019 Nursing Skills Fair, we actually included this to remind RNs that it can be done by an RN unless the provider feels like it's necessary to have speech do it. We have included this on both our ER and our inpatient order sets. And then another thing to remember maybe is if you're called to a stroke alert, to have them do another bedside swallow, because maybe the patient's been here for 2 days recovering from their hip surgery, and then they've had, either a stroke or a TIA. Again, that day of discovery starts the clock over again, so we would need to do that dysphagia screen again. Again, documentation, TIAs can be excluded. You do have to document that patient symptoms resolved. There's no need for a bedside swallow at this time. It does have to be explicit because that abstractor cannot assume that they're that just because their NIH is 0, that maybe they're not having some difficulty swallowing. So these next indicators are mostly for the ER, so I am just going to go over those briefly. I do want to mention if there is an inpatient stroke, so like I mentioned on the last slide, if we have a patient that is here recovering from some other surgery or something like that, they're here for pneumonia or they're here for surgery, but now they've had a big mental status change, and we're going to work them up for stroke. We would start the clock and count some of these as well. So current guidelines would like TPA administered within that first hour. So if they present to the ER by 2 hours of symptom onset, then administer TPA by 3 hours. And in the name of quality improvement, that number is of course ever shrinking. Just a little bit of trivia, the current record, I think as of May of 2020 is 23 minutes door to needle time. And then our longest tracked time in 2019 was 61 minutes. So we missed that door to needle time by 1 minute. The members of the stroke team which mobilize, so stroke measure 13 says that the stroke team should arrive within 15 minutes. And when we look at these times, like the 15 minutes or the blood glucose within 45 minutes or the imaging within 45 minutes, we really have to think on a national level across the board. That's a reasonable amount of time. I think Dr. Crandall is very adamant that those are big facilities, and we are almost practicing small town medicine. We can do this so much faster. And honestly, when we did mock stroke alerts, I know the ED responded to med surge and was there in less than 5 minutes. But the members of the stroke team which actually mobilize, which comes to where the patients are, is going to be lab, the house supervisor, and security. The provider is going to come evaluate the patient, obviously, and activate stroke alert orders if they feel those are appropriate. The house supervisor is going to bring the teleneurology robot, and the lab is going to stand by for orders, and then security's kind of crowd control. Now CT, which plays a hugely vital role, is going to prepare to receive the patient if needed. So in most cases, this is going to mean finishing up their current patient and holding off on putting a new patient on the table until they know if the stroke alert is coming their way. One thing I do want to stress about the stroke alert is that imaging will prioritize a stroke alert over just a regular stat exam. So the goal turnaround time, according to that stroke measure 15, is a neuroimaging order result within 45 minutes. Our average, or I'm not sure what our average is right now, but I know our fastest time goes along with that fastest time that we administered TPA, but I think our fastest turnaround time for imaging is about 13 minutes. So I recently learned that radiology has 30 minutes to open a stat read, but only 15 minutes to open and read a critical CT. And our stroke alerts are always marked as a critical when they're sent to the radiologist. So if we don't have someone in-house reading them, if they're going to Hastings or if they're going to Real Rad, and it's marked as a critical, they have to open it within 15 minutes and get that read back to it. Let's see. So the other couple of things that we get measured on are, I think I skipped over that blood glucose, but we do get a POC on stroke patients on the stroke alert orders. Obviously, we want to rule out any of those stroke mimics like hypoglycemia early on, because maybe if they're hypoglycemic, we'll go ahead and give them some medication and see if they come around before we CT their head. Again, that's kind of up to the provider at the time. And then the other one is stroke measure 16, talks about transferring for neurosurgery within 2 hours. So we do try to start arranging that as quickly as possible to get them down the road. We are contracted with UNMC with a transfer agreement for thrombectomy. But a lot of times for neurosurgery, we're going to send them, across town to Good Samaritan, or we're going to send them somewhere down the road where we have neurosurgery coverage as soon as we can. So with the little bit of time that we have left, I do want to talk briefly about some case studies that we've had that went well and some that have needed improvement. So our first case review, we have a patient that was admitted through Kearney Regional's ER for altered mental status related to infection. So she was septic and she improved with antibiotics. On the day of the event, the bedside RN noticed new dysphagia when she did her med pass. So her initial assessment of the day noted no dysphagia, no facial droop or weakness. So from the audit, we really believe that her last known well time was that 7 a.m. assessment. Rather than notify the hospitalist directly or call a stroke alert, the RN notifies the charge nurse, who says that they will discuss this during grand rounds at 8:30. So the charge nurse follows through, but because ground rounds takes a while, the provider does not order a CT until about 9:25. And honestly, I don't recall if I wrote this one down as they ordered a stat or not, but fairly decent turnaround time for just a regular one. At 11:15, the results come back and it recommends that they get an MRI. In the meantime, the nurse's notes say that the patient is now having difficulty ambulating and is weak on the left side. Now, the CT showed no acute bleed, but there was an abnormality. So, like I said, recommended the MRI. Those results were called, so they went ahead and ordered the MRI right away at 11:20. But by this time, we're already starting to get out of that TPA window. The MRI results actually came back greater than 4.5 hours from symptom onset, but it was positive for an evolving stroke. So there are lots of issues with this case, and the first and most glaring, in my opinion, is the lack of urgency on nursing's part. They noticed a change, but they failed to respond appropriately to that change. Instead, they waited an hour to reach out to the provider. the provider does the right thing and orders the CT scan, probably thinking that, well, it's not that urgent because nursing waited an hour to let me know about it. It's an inpatient scan, so it takes almost an hour from the time the CT is ordered to get results, although they were pretty close to our 45-minute turnaround time because I think they were about 50 minutes. If the provider had used the stroke alert order set, maybe turnaround time could have been maximally the 45 minutes. But again, we average about 20 minutes on a stroke alert, so that would have shaved some time off. The stroke alert orders also include a CTA of the head and neck, which may have eliminated the need for the MRI, as the lesion may have been visualized, or a blockage may have been visualized with the CTA. We really don't know if that would be the case or not. So by the time we're done evaluating this patient, there's no option really for intervention. And any deficits that they're going to have are going to have to be corrected really by rehabilitation rather than by medical intervention. So let's look at another case now. This was an inpatient that was admitted for acute kidney injury and an infected fistula. They were a direct admit from an outside facility. So the patient was here for several days, but she was alert and oriented and up until the time of her event. So on review of this one, her neurological assessment was normal at 9:30. A little after 10 a.m., the patient is confused and slurring her words. So the RN does promptly notify the hospitalist who comes and evaluates the patient. The hospitalist recommends the stroke alert, which is called at 10:40. The patient goes to CT and gets a CT-CTA, which shows no acute bleed and no occlusion on the CTA. Back in her room, the patient receives a teleneurology consult and has an NIHSS of 7. So at 11:30, the hospitalist and the neurologist confer about the TPA decision. So really we've looked at, it's taken us about an hour, which is not bad because if they're conferring on the decision, that means they've got the results back on that CTA already. Now, this patient did not receive TPA, but I do want to stress that the option was still there. In the end, it was actually the patient's comorbidities that ruled her out, but the option to discuss whether or not to treat this stroke was there. So case 2 obviously went a lot better, but there's always room for improvement. Everything can go perfectly, and we can administer TPA in 23 minutes in the ER, and we still want to be asking where we can improve. In this case, we look at the delay between the nurse calling the hospitalist and then the stroke alert being called. So 16 minutes, if you figure 1.9 million neurons per minute are being destroyed during an acute stroke, if you think about 16 minutes, that's about 30 million neurons dying. The correct studies were ordered, but the hospitalist did not use the stroke alert order set. So if after receiving the call you feel like it may be a stroke and it may be an acute change, the RN could still take that verbal order to use the stroke alert set. Radiology's turnaround time was about 30 minutes, but what if we shaved 15 minutes off of that? Other good things, the patient got a prompt neuro consult. Ultimately, as I said, this patient didn't receive TPA, and most of our patients won't. In 2019, I think we administered TPA both in the inpatient and emergency room setting, I think a total of 4 times. But the point of this is working these patients up quickly and efficiently is the key. So just to wrap up today's presentation, I hope you felt this has met the objectives of looking at what those stroke measures are, looking at some of the evidence from the guidelines for management of acute ischemic stroke, and then looking at how our order sets really play into that. There will be a SurveyMonkey link that is sent out with the presentation. This is going to serve as our attendance record for this in-service, so please make sure you take the time to fill out the survey. It's super, super short. And then, of course, if you have any questions or concerns, you can reach out to me by phone or email. My extension is 3634. If it's after regular business hours, it's usually forwarded to my cell phone. So I'm perfectly fine if you've got a question or an issue that comes up related to stroke. Please let me know. And again, thanks for taking the time to view this webinar related to quality improvement and stroke. Have a great day.